So now we move to the highlight of the day, and in fact the highlight of the meeting, which is the Tizzard lecture. And the Tizzard lecture is one of the three named lectures that we have in the Society. And Peter Tizzard was a founder member and a past president of the Neonatal Society. He was president of the ESPR and the RCPCH, and he was considered by many to be the most distinguished academic paediatrician of his generation. Following his death in 1993, a fund was established to recognise and celebrate his life, and in 1997, the Society agreed that the Peter Tizzard lecture should be given at the summer meeting. And our Tizzard lecturer today is Professor Arjan. Arjan is a professor of paediatrics at the University of Leiden in the Netherlands, and has a strong research interest in perinatal transition and resuscitation, as you will hear. His research aims to increase the understanding of physiological and pathophysiological processes of transition at birth and identify the best strategies for resuscitation. He collaborates closely with Stuart Hooper's laboratory at the Ritchie Centre in Melbourne. I'm sure we'll be hearing more about that work, and using advanced imaging techniques, animal models, and then informing clinical trials as a result of those experiments. So it gives me great pleasure to welcome Arjan to the Society, and look forward to hearing his Tizzard lecture entitled Advances in Neonatal Stabilisation and Resuscitation. Arjan, thank you.
Thank you. Well, thank you. It's a pleasure to be here. It's a great honor, the Peter Tizzard lecture. Actually, when you invited me, I have to admit I never heard of him. So what do you do when you don't know someone? You go to Google and you look up Wikipedia, and he has a Wikipedia page. And what I find very unique on his Wikipedia page is that, of course, a very impressive career, and but he also has a section about his character. And I thought that's strange, because I looked up all other famous doctors. They didn't have a subsection describing his character. And his character was, well, he didn't have much patience with fools and the pretentious. And also he was brutally frank and forthright. And I thought, okay, this guy must have some Dutch ancestors. And I would get along with him quite well. So I have something to disclose. I'm chair of the Scientific Advisory Board of Concord Neonatal. I have no financial affiliation with them. I'm a consultant for Research and Development Department of Fisher & Paykel Healthcare, and I received some unrestricted grants from SLE and Fisher & Paykel. I have also something else disclosed. Today is my birthday. Yeah, the best present ever is to give the Peter Tizzard lecture in Winchester. So transition, this is the reason why I actually got drawn into neonatology, is because I was, well, intrigued about how these babies, would transition from in utero to life out of the womb, and how they would survive, how they would thrive. And I went then to visit Colin Morley in the Walhalla in Melbourne of neonatal resuscitation. When you read papers in that time, it was coming from Colin Morley. Well, and the rest is history. Transition is still an enigma, and when I was asking as a registrar and as a fellow questions to my supervisors, there was a lot of assumption, extrapolation of fetal data or neonatal data. We actually knew very little about, the transition. And now in the last decade, we know a little bit more. We know that fetal lungs have, lungs that are filled with lung liquid. That's important because the larynx is chronically closed, keeps the liquid in, the lung liquid is produced in the lungs, creates a positive pressure. That is important for lung development. And they are not part of the gas exchange. That's what the placenta does. And then you're born, and what needs to happen, you need to clear the lung liquid, you need to aerate the lung, but also not only the pulmonary transition, but also circulatory transition is also very abrupt and large changes because fetal circulation is very parallel with shunts, and it has to stop. They need to be separate, and that quite happens quite abrupt, and these are large pulmonary physiological changes you will ever experience in your life. So it's quite intriguing. There's so much to tell, but what I would like to do is to focus on the function of the larynx, something we overlooked while we were looking into the pulmonary and circulatory transition. I would like to tell you a little bit about breathing and oxygenation and what has to do with what's the association between those two. And of course, last but not least, I would like to talk about the core clamping and why we should not do it time-based, but based on when the baby is ready. So what have we learned in the last decade? Well, whatever, if you're vaginally born or born by a cesarean, you're born with some liquid in your lung. And liquid has a higher resistance than air, about 100 times. So you need a higher pressure. If you want to clear the lung liquid, you need a higher pressure initially to clear the lung liquid. What happens actually is the babies, take a breath, and they create a subatmospheric pressure around the lung, and there's a pressure difference. And this pressure needs to be high enough to the lung liquid to travel downwards to the interstitial airways through the epithelium in the interstitial space. But what happens then is that you create a surface tension, the lung has a tendency to collapse, and you create a positive pressure because of the lung liquid in the interstitial space. And because of this positive pressure, the lung liquid has the tendency to go back into the airways. And what we learned is what actually babies do, to fight against the surface tension and return of lung liquid to prevent losing lung volume or FRC, is they perform expiratory braking maneuvers. So what they do, they take a deep breath, they close the vocal cords, they hold it, create a positive pressure in the lung, and then release it quite quickly, immediately followed by an inspiration. So they break down the expiration, and it could be about 2 to 3 seconds. They also, they have surfactant. Surfactant are little friends holding each other's hands, not only for the surface tension decrease, but also trying to prevent from lung liquid to return into the airways. And then you have the epithelial sodium channels that needs to be activated. These are sodium channels that are actually responsible for producing lung liquid into the lung as a fetus, but when you're born, by the adrenaline switch around and then it's actively pumped sodium into the interstitial space and water follows. But as we know, the preterm infants, they don't have much strength to perform all these expiratory braking maneuvers, constantly. They have lack of surfactant, and the epithelial sodium channel not quite often not very active and scarcely present. So these babies need help, and what do we do? Well, this is what we do currently. When we talk about lung liquid clearance and aeration, we give positive pressure ventilation. And we just learned that, well, the initial ventilation should be with higher pressure, or you could give pressure for a longer period to make, allow the lung liquid to travel downwards. But you also have to maintain the lung aeration, and that's this PEEP and CPAP, just to prevent from the lung liquid going back into the airways. This is what we have learned in the last decade. So nice, we did all these experimental studies, and then when we tried to translate it, we forgot that we moved over to non-invasive ventilation. And what we learned from the non-invasive ventilation, that it's not that easy as we think. And it's actually quite delicate what we perform at preterm infants. Colin Morley, when I was in Melbourne, I was already a neonatologist for 3 years, and I became a fellow in the Royal Women's Hospital. And the first thing he does is ask the new fellow, could you come over here and show this at the mannequin? Are you good in mask ventilation? Well, pretty good, yeah. So could you show us? And you ventilate, and I had 80% of leak. It was quite embarrassing, but if you just twitch around a bit, correct a little bit, and you can learn it in 3 minutes. But mask leak is one of the problems with non-invasive ventilation we have to deal with. Obstruction, we all learned that, if you overextend or flexion too much, or if you press too hard with the mask on the face, you can cause obstruction. But now also recently learned, well, actually putting the mask on the face can trigger a reflex. It's called a trigeminal cardiac reflex. That's one part of this, the diving reflex. So that's an issue, and we should look for better interfaces. But one final thing that we really overlooked is that we actually could deal with a closed larynx. And this is how we came up with it. So we did the animal experience of sustained inflation. It worked quite well in animals, intubated animals, and then we moved over into the clinical and did the studies. And we did the measurements. As you can see here on the right side, baby was not breathing, and we gave a sustained inflation. The top one is the pressure, mask pressure. Middle one is the green one is the flow, and the tidal volume, expired tidal volume, and the red bars, that's what the range where you're aiming at, between 4 and 8 mils per kilogram. And as you can see, we give a sustained inflation, but there's no air going into the lung. If you compare that with a baby that was actually started to breathe, as soon as you give a sustained inflation, there was air coming into the lung. That's well, okay, apparently only air is coming to the lung when the baby is breathing. And that might be the larynx that has to do with it. So we went back to the literature and thought, well, actually, that makes sense, because as a fetus, as I told you, the larynx is predominantly closed. And that's important because you want to keep the lung liquid in, and that's produced, creates a positive pressure for lung development. So occasionally opens, but most of the time it's closed. And we know that a neonate, that when you want to breathe, and as us, is that you need a patent larynx to get air in and out of the lung. But what we don't know is when this switch of fetal function would occur. And it might well be that during transition, so during the resuscitation, the first 10 minutes, that we're actually dealing with a closed larynx in the babies that are not breathing, and we're trying to ventilate. So we went back to the synchrotron, and as you can see, this is a pup on the preterm rabbit pup on the side. We just moved over the camera from the lungs to the larynx. You can see the arrow. It's just a bit, the arrow is not in the right position, but it's just on the right. You can see the larynx. And this is a stable breathing pup with aerated lungs. And as you can see, the larynx is open most of the time. So this is a closed glottis, because he's not breathing, and his glottis is closed. This is an unstable preterm rabbit pup. Probably is hypoxic. Sometimes it takes a breath and then it opens. And then this is a pup we're trying to ventilate non-invasively, and as you can see, we're actually ventilating the nasopharynx that's distended, but we're not ventilating the lungs because there's a closed glottis. So that was pretty convincing, but what you need is actually, calculate the data or analyze the data. And as you can see, we divided the pups between the stable and breathing and the ones that were unstable and not breathing, the ones we're trying to help. And as you can see at birth, the percentage of time when the glottis was open, when the stable breathing is 90% of the time. But when they're not stable, it's 25% of the time. And these are the ones we're trying to ventilate. We're probably not aerating the lungs then. After 1 hour after birth, all pups were actually, most of the time, the glottis was open. So there's a transition in the fetal function, or the function of the larynx. But are preterm rabbit pups similar as human beings or human infants? So we tried to translate this and say, perhaps we could also see the human infants. Well, we have this ultrasound, and all you need is a neonatologist who's very keen to do ultrasounds. He's very good at it. And he just put a little bit of gel on the larynx or the larynx, and puts, without pressure, the probe on it to see if we could see it. And actually, we did at birth in preterm infants. On the top one, you see in the midline, you see actually closed vocal cords. You see the arytenoid are close to each other. And when the baby takes a breath, it's distended, and you see less egalucent area, because the vocal cords are open, it's air. So here what you see is an ultrasound of a human preterm infant that's actually breathing. And as you can see, that when he's taking a breath, the larynx is open. When during expiration, after expiration, the larynx is closed. This is actually preterm rubber pup that's doing expiratory braking maneuvers. So we could, make sure if that was inspiration, expiration, we could synchronize it with the respiratory function monitor, and actually you could see when the baby was breathing in and baby was breathing out. And as you can see on the respiratory function monitor, the baby was taking expiratory braking maneuvers, and then the larynx is closed. So if we're trying to ventilate in between because the breathing was insufficient, most of the time you would not reach the lungs. But most important, this is a baby that's not breathing. The larynx is closed. This is handling of the baby. But then the ventilating, here you go, a little bit of bubbles growing to the vocal cords, but you're ventilating against the closed vocal cords. So in summary, what we see in the preterm rubber pups, we also see it in human infants. And this is the problem, is that we're trying to ventilate babies with closed vocal cords. Of course, if they become severely hypoxic, the muscles will relax and the larynx will reopen, but that's not a healthy start of life. So when we consider this, that, hey, you need a patent airway, and that's dependent on breathing effort. If the baby's breathing, then you have a patent airway. Good news is, because not all bad news, good news is that most preterm babies actually breathe at birth. These are not, most of them are not born asphyxiated. And this breathing is insufficient. They need our help. And what we could do, instead of trying to take over, is stimulate and support the breathing in an adequate way. So what we know about inhibition and stimulation of breathing? Well, if you read the literature back in 1975 to 2004, they did a lot of experimental research on it. We know that actually a fetus is also breathing, but its breathing is suppressed, so its breathing is minimal, small tidal volumes, and it's irregular. Because it's suppressed, it's inhibited by a low level of oxygenation. And even when they become more hypoxic, for example, if they, if there's obstruction of the cord or something else, contraction, they actually stop breathing. That's because of the hypoxia, adenosine is produced, and that inhibits breathing. And then the placenta also produces prostaglandin, and that also inhibits the breathing. It's all on the brainstem, inhibits breathing. And then you're born. You need to aerate the lungs, you need to large tidal volumes, and you need to start breathing regularly. Well, what promotes it, has been known, is actually oxygenation. CO2, conflicting results, depends on what article you're reading, whether it's really the hypercapnia, why they start breathing or not. So I made it plus minus. And then we have the trigeminal guard reflex, as I said, that could inhibit breathing. When you put a mask on the face, they just can become apneic and bradycardic. And also a role of the pulmonary stretch receptors. These are the small nerve fibers around the capillaries in the interstitial space, and they can be triggered. It's very pressure sensitive. So when the lungs are aerated, so the lung liquid clearance into the interstitial space, the positive pressure is triggering the pulmonary stretch receptors, and that could also, via the autonomous nervous system, stimulates breathing. And last but not least, of course, as we all do in the delivery room, but we often forget, is the physical stimuli. Tactile stimulation, light, cold, all these things could stimulate breathing. So we have taken that, to the animal experiments and then performed the clinical studies on tactile stimulation, because if you read the literature, there's actually, we have done it for decades, but there's actually very little known about tactile stimulation, if it works or not. So what we did, we compared or standard tactile stimulation with repetitive tactile stimulation, because even if we have shown in our unit that most people would forget to do it in preterm infants when they were wrapped, they were not prepared, they didn't have an equipoism to say, okay, well, let's compare no tactile stimulation versus tactile stimulation. And we showed actually that the minute volume increased when you did repetitive tactile stimulation. Caffeine, instead of giving 10 minutes after birth in the unit, we would give it immediately after birth. And we've shown actually that also increases the breathing effort. But What we also saw is that it didn't work in every infant, and it actually depended, as we analyze it, on the oxygenation level. So that makes sense, is that actually the most dominant or the highest in the hierarchy is actually the oxygenation that actually defines if the baby's breathing and if other interventions would work. And that's a very important message, because this is what we've been doing. This is all over the world. We moved over from 100% and not titrating to 21 or 30% and then titrate, trying to help these preterm infants. And I think it makes sense to avoid the hyperoxia, but what we exchanged the hyperoxia for allowing them to be hypoxic in the first 5 minutes. On the right side, that's Rotterdam in the Netherlands. In the middle, that's Melbourne. And on the right side, I think that's Edmonton in Canada. So all over the world, you see the same thing in preterm infants. In the first 5 minutes, most of the infants are getting pretty hypoxic. They relax their larynx, we start ventilating, we increase the oxygenation, then they go up. So perhaps we should not only avoid hyperoxia, but also avoid hypoxia in the first 5 minutes to stimulate the breathing effort. That's what we did in the animal experiments. We came up with a non-invasive or an experimental model of spontaneous breathing pups. We supported with CPAP, and we compared 21% with 100% of oxygen. And we observed in these preterm pups is that actually the preterm pups that received 21% became hypoxic, and they just stopped breathing. They became apneic. And that was significantly less in 100% of oxygen, even if they became hyperoxic. And the 100% group, of course, the variability of interbreath, they were breathing more regularly, and there was a higher respiratory rate. So we translated that into a small trial where we did direct measurements to measure the effect of oxygenation directly at birth. So we looked at the respiratory function monitoring, the minute volume, the respiratory effort. If you see that what we did was 100% and then carefully titrating down to avoid hyperoxia. And then compared to the standard group, we would start with 30% in extreme preterm infants and then titrate up as, conform following the guidelines. If you see it, the amount of FiO2 given, that's not different between the groups, in total. But if you look at SpO2, you see that the ones that we have been, starting with 100% and titrating down, they reach the target range much sooner. And that had an effect on the breathing effort. The minute volume in the 100% group significantly higher, was almost double as the one with, where we started off with low oxygen. And it was consistent over time, as you can see on the top one, is that actually over time points in the first 5 minutes, they were consistently breathing more than compared to the 30% group. Of course, we were a bit afraid of inducing hyperoxia, and then with Ola Stasso with breathing down his neck, saying that we were doing terrible things. So we better make sure that we measure that, and we measured in the blood, in the cord blood, and then 1 hour after birth and 24 hours after birth, one of oxidation markers, and actually it was not different. Why? Well, we had a researcher present during resuscitation who did the careful titration. And I think that lies the answer, the careful titration. So perhaps it's not really the question, what kind of level you should start. Why not start with 100%? Because, well, we're not very good in creating FSC. We compensated that with oxygenation, with FiO2, but we do the careful titration. I think the answer lies in careful titration and not let them to be hypoxic and hyperoxic. The other thing is the trigeminocardic reflex. This is retrospective data. We do standardly in our unit, we do recording, respiratory function monitoring, video, and we review them, and we also do auditing. But what came out is that actually we observed when we were reviewing these recordings that some of these infants were actually stopped breathing when we put the mask on the face. And so we reviewed all the recordings, and we actually found out that more than half of these preterm infants stopped breathing when we put the mask on the face, and there was breathing present before. And that's a trigeminal cardiac reflex. It's a nice reflex. It prevents you from, when you become hypoxic or asphyxiated. It preserves the use of oxygen of the heart and the brain, and it makes you bradycardic. And it closes the vocal cords to prevent aspiration. Great reflex, but inducing this in preterm infants where we're trying to help them might be not really the best way to do it. And the more preterm they were, the more sensitive they were for applying a mask on the face. Is then a different interface better? We compared it with a binasal prong, and actually didn't make much difference. And we think that the reason why that is because they were holding the binasal prongs with the hands, and you're still, touching the sensitive area between the nose and the mouth, inducing a TCR. And perhaps we should look more into better interfaces for these preterm infants. We're just learning about this. Then the support. Although in the world it's a very static pressure we're using to support breathing, CPAP pressure for 5 to 8, depending on which unit you're working. But if you look at the physiology of the pulmonary transition, the lung liquid clearance, aeration, and maintaining aeration, it actually makes more sense to start off with a higher CPAP pressure and let them breathe. They aerate the lungs, and once they have aerated the lungs, then you can titrate down the pressure because you need less pressure to maintain the lung volume. We showed that in animal data. As you can see, we did animal experiments in rabbits and in lambs. On the top one, we measured the FSC in the synchrotron, and you could see that the higher the CPAP pressure, we went until 50 centimeters of water, different groups. You see actually that the FSC was higher, so we gained more lung volume. Less apnea when there was a higher CPAP level. There was also caution about, giving a higher CPAP level, perhaps we're interfering with the pulmonary blood flow, and you have a deleterious effect on pulmonary blood flow. You get less pulmonary blood flow because you're over-distending the lung. It was actually the other way around in the lambs. The higher the CPAP level, the better the lung aeration, and actually there was an increase in pulmonary blood flow when compared to lower CPAP levels. Would you compromise the cerebral blood flow? Well, actually didn't make much difference. So that was encouraging, and that's why we did a small feasibility trial in what we call physiological based CPAP, a dynamic CPAP level, starting off with 15 and then titrate down to 8 according to certain criteria. When you look at SpO2, it didn't make much difference. Why? Well, we were very trigger happy with the FiO2. As you can see, is that we immediately increased the FiO2, and that masked the effect on the SpO2 of the lung aeration, creating the surface area for cross exchange. But if you look at the heart rate, and again, this was a small feasibility study, these babies had sooner a heart rate above 100 than the infants that were receiving the standard CPAP level. And that reflects actually, creating lung aeration, because that increases the heart rate. That's been known. But what we really found out is actually, because this makes sense, and we need more studies on it, on physiologically based CPAP. But what we also found out that the caregiver found it very difficult to take all these steps in dynamic CPAP level. It's too complicated for them. It was an extra researcher present, a PhD student, who would tell all the steps, but it would never be practical, in daily life. So we should come up with a more simple approach. Perhaps, starting off 15, and once the baby's stable, titrate down to 8. But we need more data. I'm not recommending it at the moment. We need more data on that. But there's some sense into it to have a dynamic CPAP level. So core clamping. Let's move over to core clamping, because what I want to show you guys is that actually the pulmonary transition is intimately linked to the circulatory transition. And we have different choices of core clamping. You can immediately clamp the cord, as shown here. You can wait until the umbilical cord is pulseless or wide. That's what the midwives have been doing for centuries. I'm exaggerating, for decades. And then that probably makes sense. This is quite popular in the Netherlands at the moment. It's the underwater birth. So it's in a plastic bath, and you have the placenta. You can make a little ceremony out of it. You put the placenta in a bowl, and then the father has also something to do. Well, I assume that's the father, but you know that if you look for placenta transfusion, there's very little going to the baby in this way. You can wait a little bit longer. That's the lotus birth. I don't know if you're familiar with lotus birth. That's coming from the yoga world. The rationale about the lotus birth is that the most traumatic event that you will ever experience in your life is getting separated from your mother. So do it gently and slowly. Just wait until the placenta drops off. It gets smelly. They have special herbs to make it smell nice. You have special bags to carry the placenta. And last but not least, I hope most of the men recognize it, sometimes the cord doesn't get separated. Of course, I'm more scientifically interested in the early cord clamping versus delayed cord clamping. There are two potential benefits of waiting with clamping instead of immediate clamping. First is the placenta transfusion. That's blood going from the placenta going to the infant. So you can benefit from an extra volume of blood. And the second is there's a hemodynamic benefit if you wait with cord clamping. And that's perhaps even a larger benefit than the placenta transfusion. But that's up for debate. So the placenta transfusion, that's been in the recent years, been a hot topic. A lot of trials have been performed. And there's always, referred to all the data about the placenta transfusion, blood going from the placenta to the baby. And there's no doubt there is a volume of blood going from the placenta to the baby, because that explains also the increase in birth weight. But there's so far not really a good scientific explanation of how that works. And it might well be because we have shown that actually gravity makes no difference. If you put it below or above, it's not the driving force for placenta transfusion. We've shown that actually uterine contractions, that we thought that was the driving force, is not the driving force. Actually, when there's a uterine contraction, the circulation stops. But what is the driving force? Well, you have to see that, it's a fetus, and this fetus has an extra organ. And that's the placenta. There's about 130% of blood. And about 40% is in the placenta. And what might happen is that it's not a transfusion, but restoration of a balance. The baby has this, undergoes these uterine contractions, and this pressure from the side could mean that there's a disturbance in the balance. And there's no blood from into the placenta than in the baby. And if the baby is born, if you wait a while, perhaps that's the restoration of the balance, and then blood goes back into the infant. It receives back what he actually was his or hers. And that's not really a transfusion, that's more a restoration of balance. But this also has to be proven because this is just a hypothesis. What we actually show, what even actually influences the venous return, so what blood going from the placenta to the baby, is the breathing effort. And this is Doppler on umbilical vein. As you can see, there's an increase of flow, decrease of flow, and that was actually similar, synchronous with the breathing of the baby, inspiration, expiration, inspiration, expiration. And we also measured on the ductus venosus. And what we actually observed, or you see on the right, is what happens is that the baby takes a breath, takes an inspiration, there's a collapse of the inferior vena cava. So there's no blood coming from the inferior vena cava, and there's an increase of blood flow coming from the ductus venosus and the hepatic vein. So apparently there's a preferential blood flow then into the baby coming from the placenta. So it might well be that breathing effort, and breathing is then important to get a good result in the placental transfusion, restoration of the balance. But there's an even larger benefit, might be more beneficial, and that's the hemodynamic benefit. And that's, to understand that, we have to go back to the fetal circulation. So this is a schematic drawing of fetal circulation. Let's start with the placenta. The placenta oxygenates the blood. Oxygenated blood goes through the umbilical vein, and then you get the ductus venosus. And this is very schematic drawn. If you do an echo, you would actually know that the ductus venosus is entering the right atrium, very close to the right atrium. And this ductus venosus has this typical shape, a tunnel-shaped form, and that causes a turbulence. And with the little ridge on the right atrium, that this turbulence causes that most of the oxygenated blood goes directed via the foramen vale into the left part of the heart. That's to oxygenate, to bring the oxygenated blood to the heart and the brain. Then the baby, the venous return of the baby, vena cava inferior and superior, it enters the right atrium, and most of it gets into the right ventricle and gets pumped into the lungs, but the lungs has still a high pulmonary vascular resistance because they don't, not responsible for the gas exchange. The liquid filled. And most of it gets bounced back because of this high resistance, about 80 to 90%, through the ductus arteriosus into the systemic circulation. And because the placenta is a big ball of vessels, it has a very low resistance, most of it gets directed into the placenta, so it can get oxygenated, the blood. If you know that the venous return from the placenta at that time, depending on what gestational age, is that about 35 to 50% from the venous return into the heart is coming from the placenta, and that you will miss out as soon as you clamp the cord, you will start thinking about, okay, it might well be that you have deleterious effect on the cardiac output. So if the baby's born, this is what happens. The lungs, if everything goes well, lungs are liquid filled, or clear from liquid, there's lung aeration, you get an increase of pulmonary blood flow because the resistance decreases, and the lungs are responsible for the gas exchange. And then you get an increase of pulmonary blood flow in the left part of the heart. The other thing that happens is that we clamp the cord. And what happens when you clamp the cord, you miss out the 30–50% of cardiac output from the placenta, plus you have an instant increase of systemic vascular resistance. So if the lungs are not aerated, still the left part of the heart is still dependent on what's coming from the placenta. You miss out 30–50% of your cardiac output, plus you have to pump against a higher resistance, so you have to increase in afterload. So that might not be very beneficial. It better be that you wait with lung aeration, so then the left part of the heart is more dependent from the pulmonary venous return than what's coming from the placenta. So we tested the theory, but what's important to know is that what actually does the pulmonary blood flow increase, because we've all been taught it's locally substances like nitric oxide and oxygenation, but this is a preterm rabbit pup from the synchrotron, and you can assure you he or she has been intubated too deep. That's on purpose because we want to ventilate one part of the lung. And then we put iodine in the pulmonary blood flow to see what happens to the pulmonary circulation. So this before aeration, very little pulmonary blood flow. And then we start aerating one part of the lung. And you see actually an increase in both sides, also the unaerated part. So there's actually a ventilation perfusion mismatch if you don't have a nice uniform lung aeration. But that's why we found out that actually the lung aeration is the master switch for increase of pulmonary blood flow. And oxygenation helps, it's a mediator, but the initial increase of pulmonary blood flow is a neural reflex. And that has to do with the juxtacapillary receptors, because if you do a vagotomy, it's gone. And that makes sense then that aerating the lung is the primary thing that we need to do that also triggers the increase of pulmonary blood flow. So we tested this in lambs. And we did, cord clamping followed by ventilation. That's actually what we've been doing previously, as soon as the baby's born, we're still doing it in preterm infants, clamp the cord, bring it to the table to resuscitate it or stabilize it. What you actually see on the top one in these lambs, heart rate would decrease and then increase when you start ventilating. And that makes sense because you miss the cardiac output, you could become bradycardic, is a well-known phenomenon. Instant loss of cardiac output. The first thing that happens is you become bradycardic before you become tachycardic. And you start ventilating, then the left part of the heart is more dependent from coming from the lungs, and then you get restoration of the bradycardia. The right ventricular output, same thing, you get a decrease of right ventricular output and then an increase. If you look at the carotid arterial pressure and blood flow, you actually see first an increase, followed by a decrease, followed by an increase. And that has to do by, it increased first because suddenly the heart has to pump against increased systemic vascular resistance. And then it noticed that it misses out the cardiac output, you get a decrease. And then you start ventilating, you get an increase. We all know that preterm infants, especially the brain, are quite susceptible for these swings in blood pressure and blood flow, and you could actually induce an IVH. So what if we ventilate before cord clamping? So you first aerate the lung, in the left part of the heart, it's more dependent on what's coming from the lungs instead of the placenta. So when you then detach or clamp the cord, you can see that it's a more subtle, more gentle hemodynamic transition, and you don't get these large swings. Oxygenation, different experiments, same, comparing physiology-based cord clamping with immediate cord clamping. On the bottom one, on the left, you see the SpO2. You actually can see, you recognize this dent in clamping first. This is what we see often in the clinic, the hypoxia. And you need to increase the oxygenation, you need more oxygen. When you compare it with physiology-based cord clamping, there's actually smoothly increase of oxygenation and you need less oxygen. Same goes for the cerebral oxygenation. And if you look at the cerebral blood flow, there's actually in the clamp first and then ventilate, increase the cerebral blood flow. And that's also a well-known compensation mechanism for hypoxia. So if we want to translate this to the clinic, we wanted to make sure that we could stabilize infants and clamp the cord until the babies are ready. That means if you want to not compromising in all the care you normally would give, I wasn't happy with what was currently available at that time and resuscitation table. That's the only reason. I was not aimed to become the inventor of resuscitation. I was only looking for something that I could use to translate the findings in the experimental studies. So we came up with a Concord table. It has a platform with a slit, so you can easily move the platform as close as possible to the birth canal because these umbilical cords can be very short in preterm infants. And we all the time, so that was the aim, that you could do everything you wanted, prevent hypothermia, ventilate, stabilize the infants, give oxygen, stimulate until the baby was breathing and stable, and then clamp the cord. But it's a nice table, but we also realize it's not only a device that you put into the delivery room, and let alone in the operating theater, you have to have the whole team on board. It's a workflow you're creating, and it's a complete change of culture. You need the obstetricians on board, you need the anesthesiologists on board in the operating theater, and especially you need the nurses on board. And because they are standing somewhere else than where they used to, and it's all, challenging in the beginning. That's why we decided to first let me tell you why we came up with the clamping criteria. Of course, we can't look at lung aeration. When the lungs are when there's increased blood flow, we don't have a synchrotron in the delivery room. So we reviewed all the recordings we have and see, well, when could we define when the baby is stable and breathing on CPAP and a heart rate above 100, and SpO2 above 85% with less than 40% of oxygen. This is based on all the data we have. This is the clamping criteria. So we will wait until the baby reaches the criteria and is stable or ventilated, because sometimes they don't breathe, and then clamp the cord. It's physiological based cord clamping. We did a feasibility study. I'm just showing an example of recording. This is, I forgot how young this infant was. I think 27, 28. It's wrapped. It's placed on the cord, on the platform. It's pushed a little bit forward to make sure there's no stretch on the umbilical cord. Head is on, and they are, as usually, struggling to get the pulse oximeter around the wrist. But this is what happens. As you can see, the baby is moving, so probably is doing okay. Then there's the mask on the face. And this is in Rotterdam. They use 21% of oxygen. As you can see in the respiratory function monitor, the baby's spontaneous breathing, nice tidal volumes. So